And then suicide is a continual problem-solving strategy. So this is different. I'm not talking about the person that comes in with suicidal thinking, because when someone's severely depressed, that's quite normative. What I'm talking about is the person that comes in and when they're in distress, this is their go-to. This is their solution. And we know quite a lot of folks who go to this because they get so overwhelmed. Dr. Hudler was talking about the amygdala becomes flooded, the prefrontal cortex kind of shuts down, and immediately they go to, well, suicide is my best option. And we really want to teach folks that that's not your only option. And in fact, it's a pretty ineffective strategy for you to be able to cope with your life. Threatening to harm others, walking out, leaving session early, right? That's an acting out behavior. And some of these, let me just say, you could cross these, meaning some of the avoidance behaviors could be seen as acting out, and some of the acting out could be seen as avoidance. This would be one of those. Like maybe they're walking away because they don't want to deal with the conflict in the room. So this isn't sort of a black or white thing. There's a lot of gray here. Not paying for sessions. There's that. Acting on erotic transference. So the idea with erotic transference is that the patient is experiencing maybe a sexual attraction to the therapist based on something that reminds them somebody that they are thinking about, or just they're attracted to the therapist. Now, I'm not saying that that's a bad thing, right? If attraction in relationships is somewhat normative. So if a patient has a sexual attraction to their therapist, we don't want to pathologize that. That's not a bad thing. But if they begin making inappropriate sexual comments, right, to try to get elicit a response, or they start giving maybe grand gifts or inappropriate gifts, that's where we could flag it as an acting out behavior and something that we'd want to definitely bring up in treatment. Attempting to control the session, trying to take charge, and splitting between providers. And I look at this as acting out because let's say I'm a good therapist, right? And I'm told that this other therapist sucks and they're no good, right? It might be seen as an acting out behavior because ideally we want to help the patient to communicate directly to this other therapist what they're thinking and feeling. But by telling me and then maybe quitting on their other therapist, they're acting out versus dealing directly with their thoughts and feelings. So again, splitting between providers could be seen as acting out. So now what we're going to do is we're going to look at specific interventions to address avoidance behaviors. That's where we're going to start, okay? And how I've put them here, on the far right-hand side, or your left, it's going to be interventions to build the relationship. And as you know in therapy, if you don't have a relationship, you don't really have anything. It's like money in the bank. And I think we get so eager and so focused, maybe Dr. Reyes was talking about the technician, right, the manualized treatment, like, ooh, I know how to deal with this. I'm just gonna jump in and we're gonna treat the depression at ABC. But if you forget that there's a person in front of you, if you forget that this person just went through something horrific and you don't connect with them on that, you've lost them, right? It takes a long time to build trust sometimes with these folks, and at the same time, we really gotta be careful to see them as people and not just diagnoses. And I know all of you know that. Right? So we're going to be talking about validation, empathy, normalizing difficulties, inquiry, and Socratic questioning. And then the next one is identifying the function, right? This is the big key of why we're here today, is to really look at what is the function of these behaviors based on an accurate case conceptualization. And then how to get unstuck. Has anybody ever been stuck with a patient before? Just me? Oh, a few of you. Oh, okay. Okay, Kelsey, I saw that. All right. So we're going to look at a tool called pros and cons. We're going to look at devil's advocate as another strategy, the paradox, and then identifying distorted thinking. And then lastly, we're going to look at the theme of how to elicit commitment from your patients. So in your first session, ideally, your first or second session, you want to identify a treatment plan. And the treatment plan is a collaborative engagement saying, here's the problem and here's some strategies we're going to use to deal with the problem. Are you on board with that? And ideally the patient's on board, and then if you notice throughout treatment that you're getting stuck, these are going to be some strategies to help you re-elicit that commitment. So it's going to be looking at the dialectic, the foot in the door, door in the face, and then shaping. So let's get into it. So let's talk about building rapport. I know, who has not heard of validation? Anybody not heard of validation? Okay, good. So I thought so. But let me talk about validation for a second because, okay, the strategy is to connect. That's the point. And that is, again, one of the most important things is to connect with your patients, because if you don't have that, they're probably not going to work with you, and actually it's going to make your life harder. So to make your life easier, you want to validate. But validation is different. So let's say I have a patient comes in and they're severely depressed, like vegetatively depressed. Have y'all ever worked with someone who's vegetatively depressed, right? They're struggling to get out of bed. They're struggling with ADLs, right? That can become frustrating because you just want to be like, come on. So validation, if you think about that person, maybe they're down in like a well. They're down in this dark hole, because that's what it feels like. And so maybe you could, you kind of up top in the well and you're kind of peeking down and you're like, whoa, it looks dark down there. What's it like? Ooh, kind of scary. And maybe you like throw them a rope, but you're kind of staying away from it. That's not validation. Validation is you're going to actually climb down into that well. You're going to get down in that well with them, and you're going to maybe light a match and say, wow, it's really dark down here. How scary for you, right? You're going to get on their level and you're really going to see them. And I'm not saying taking on their feelings, but you're actually going to be with them and be in that space. And that actually takes a lot of skill to tolerate that level of depression. So my example is, it makes sense that you didn't want to do that assignment. It was really difficult. Can you tell me what was difficult about that for you? So again, I'm understanding and empathizing. Makes sense you didn't do that because it's really hard in your state to do that. Whether I fully get that or not, the point is to convey empathy so that I can build that relationship so they'll trust me. Okay, so normalizing difficulties. Our mental health population is incredibly stigmatized. You know it and I know it. Even talking about mental health issues in the news, it's not really done. We're so behind in terms of being able to talk about these things in the open and really to normalize those challenges. And I have so many patients that come in and say, people tell me I'm crazy, I must be crazy, there's something wrong with me. And so really all people want to hear is that they're okay. And that, it makes sense how they're feeling based on what they've been through. So I think anyone in your position would have felt the same way. Something simple like that, right? Just to normalize, like it makes sense that you're going through this based on everything that you've gone through. And inquiry. Okay, so what do I think about inquiry? Because there's a lot of different ways we could do this. Inquiry is basically using your curiosity to ask questions and to really get to know the patient. So for example, how come you didn't call me when you realized you were going to be late, right? The key here is my tone. I'm inquiring, I'm trying to understand them better, because it could go really different, right? I could say, how come you didn't call me when you realized you were going to be late? Okay, that's going to set a different tone. That's going to set more of a judgmental tone. So the idea is that we want to take a more non-judgmental stance when we're inquiring, when the intention is to build rapport, to understand, to connect. And if you have a highly avoidant patient, that is what you want to do, because they're already skittish, right? So you want to make sure that you're able to try and connect and build that bridge with them. And then lastly, Socratic questioning. So Socratic questioning is one of those things where you have an end game. You're looking to lead the patient down the path so that they will discover something you're hoping that they will discover, and also so that you can understand them better. So for example, what does it look like when you shut down? There's a dual function in that question. First of all, I'm asking the patient to ask themselves, what does it look like when they shut down, so that they can discover, oh gosh, next time I shut down, maybe I'm going to start to notice it and maybe I can do something about it versus just shutting down. And then it's also a function for me because I get to know what they look like when they shut down so that when it happens in session, I can do something about it, right? So that's the dual function. And then also, how might it benefit you to speak up even when you feel uncomfortable, right? So I'm guiding them to think about the fact that they don't speak up and what might it look like if they did, or what would be the benefit even though it's highly uncomfortable for them. So that's that sort of guided discovery, trying to get them to understand things about themselves. And me too, I'm trying to understand them better. So